Hopefully by the end of this talk, you'll be a bit more familiar about why and when to use CRIs, understand why we administer a drug bolus before starting a CRI, how to set up and administer a CRI, how to calculate them, and then the main drugs I'll talk about are fentanyl, ketamine and dopamine, because these are the more common drugs used within theatre. So why do we administer CRIs? The main reason is for analgesia, but we also use dopamine, for example, for blood pressure. Dopamine especially is very fast acting, so the only way to administer it is through a CRI. We can use CRIs alongside other drugs as well, so this reduces the reliance on one particular drug, and lower doses of these drugs can be given alongside each other, therefore reducing side effects seen at higher doses of one particular drug. So when a drug is administered intravenously, the plasma concentration rises rapidly. The drug is then redistributed to tissues, metabolized and eliminated. Over a period of time, and this time will differ depending on the drug that we're using, the plasma concentration falls, and this in turn reduces the effect of the drug. To avoid changes in plasma concentration and maintain analgesia, which will also help aid a smooth anaesthetic, we may choose to start the CRI. The graph shows the plasma concentration over time. We can see that with a bolus and the initial intermittent dose, the plasma concentration rises rapidly. Without a bolus, it takes longer to catch up. After the bolus, you then start your CRI, and this helps keep the plasma concentration at an acceptable level without the peaks and troughs seen with the intermittent doses. So next we're going to talk about how to actually set up the CRI. So this can be administered via a fluid bag or a syringe driver. Ensure everything is labelled. So with that you need your patient name, the drug name including the dose and concentration, the date and time that it's set up, the prescribing vet, and your name or the name of whoever is setting it up. It's also important to remember to label your giving set as close to the connector on the IV cannula. This is because it's much easier to identify when you're looking under the drapes. So the next step is how to calculate a CRI, and this is for the undiluted. So the required information you need is the dose, the weight and the drug concentration. You need to remember that you need your dose and your drug concentration for the same unit. So that's either milligrams or micrograms. So step 1 is your dose times your weight will give you your mg per minute or your microgram per minute depending on your unit that you're using. Your step 2 is your mg per minute divided by your concentration, which is your mg per mil, which will give your mil per minute. And step 3 is your mil per minute times 60, because we're then converting it to an hour, which will give you your mils per hour. Obviously you won't need to do step 3 if your dose is mg per kg per hour. And as with any calculation, you always want to get a second person to check this. So next will be how to calculate a diluted CRI. So if you're given your dose in micrograms per kilo per minute, step 1 would be your microgram times your body weight times 60 divided by 1000, which will give you your milligrams per hour. We use 60 because obviously we're converting minutes to hours, and 1000 because we're converting the micrograms to milligrams. Step 2 would be your milligram per hour divided by your mil per hour, which is the fluid rate that the vet would like the CRI on, and that will give you your milligram per mil. Step 3 would be your milligram per mil times your final volume in your bag divided by your drug concentration, and this will give you the mil of the drug that you need in that bag. Your final volume in your bag could be anything from 100 ml, 500 ml or 1 litre, but just remember, if you're using a litre bag, you need to put 1000 ml, not 1 in there. If when you're in surgery they want to change the dose rate, you need to alter your dose rate for whatever reason. To alter the fluid rate, because obviously we do the fluid rate rather than setting up a new bag with a different concentration in, you would then do your new dose divided by your original dose and times by your original mil per hour, which will give you your new mil per hour. So an example of this would be if they wanted 5 micrograms per kilo per minute at 25 mil per hour. So for a fluid rate, we're using 1 mil per kilo per hour for a 25 kilo dog. And we want to increase this dose rate to 10 micrograms per kilo per minute. So you would do 10 divided by 5 times 25, and this would give you 50 mil per hour. So you're effectively doubling your rate. So the first drug that we'll talk about is fentanyl. So fentanyl is a very potent opioid analgesic, and we use it during surgery to treat moderate to very severe pain. It can cause depression of the central nervous system, and the main side effects that we come across are bradycardia and respiratory depression. So we need to be really careful when administering boluses that we give really slowly, but obviously be prepared that you may need to ventilate if it causes apnea as well. For fentanyl, it's the same dose for cats and dogs. As a bolus, you can start from 5 to 5 micrograms per kilo, but be aware that within the 20 minutes, you can't give more than the 5 micrograms. The concentration is 50 micrograms per mil, and a CRI, we would start at 10 micrograms per kilo per hour. As I just said, they administer it very slowly, rapid onset of sort of 1 to 2 minutes, and it lasts approximately 20 minutes. So a CRI of fentanyl can be started at the beginning of surgery, but most commonly we do it intra-op. We find that if we're needing to give more than 2 or 3 boluses of fentanyl, and we've still got quite a bit of surgery left, then that's the sort of time when we'd look to start the CRI. Ones that are starting before surgery would be the ones that were preempting that they're going to be painful, so sternotomies, but also patients that are presenting with a really high pain score at the start of surgery, then we would look to start them on a CRI at the beginning. And then we would stop the CRI at the end of surgery. So an example for how to calculate your fentanyl. So as a standard, we use a starting bolus dose of 2 micrograms per kilo, and the concentration is 50 micrograms per mil. So for the example, the weight that we're using is a 10 kilo dog. So you do your body weight, so 10 times 2, which gives you 20 micrograms. Divide that by 50, because that's your concentration, and this gives you your bolus of 0.4 mil. And you can give this every 20 minutes, but you can also up that dose to 5 micrograms within that 20 minutes if need to. Your CRI dose is 10 micrograms per kilo per hour. So we're using the same weight, so 10 times 10, so that's 100 micrograms per hour. Again, you divide that by your stock concentration, which is 50 micrograms per mil, and that would give you 2 mil per hour. So you would set your syringe driver for the fentanyl at 2 mil per hour. But bearing in mind that when you are drawing up your loading dose is 1.7 for your syringe driver giving sets, so you would need to draw up a bit extra for that. So the next drug is ketamine. So ketamine is an N-methyl D-aspartate receptor antagonist, and these receptors play a role in the neurological function. So ketamine can be used for sedation, anesthesia or analgesia. Side effects are commonly dysphoria and hypertension, but for the CRI purposes, it's for analgesia. And also for analgesia, the same dose for cats and dogs. So you'd start with a bolus of 0.5 mg per kg, and the concentration is 100 mg per mil. The CRI that we tend to do is 0.6 mil of ketamine in a 100 mil bag of saline, and we run this at 1 mil per kilo per hour, and this gives us a dose of 10 micrograms per kilo per minute. So always remember that when you're setting up your CRIs that you remove the 0.6 mil of saline from the bag before adding the ketamine, and this will ensure you give a correct concentration. It's always worth having a separate fluid bag of crystalloids on the patient as well, and this will help with your normal fluid rate but also help with any boluses, so you don't have to adjust your ketamine. Post-op, we usually reduce the ketamine fluid rate to 0.5 mil per kilo per hour, but leave the bag concentration the same, so you're effectively halving the dose, and then stop when the patient's pain is comfortable and you're getting a lower pain score. And so an example to work out your ketamine, so we've got the weight at 10 kilos, the dose for a bolus is 0.5 mg per kg, and the concentration is 100 mg per mil. So we're 10 times 0.5, which gives us 5 milligrams. Divide this by 100 milligrams per mil, which gives us a bolus of 0.05 mil. And we give the bolus when the patient's already in theatre and we're starting to prep in there. For the CRI, we're putting 0.6 mil of ketamine in a 100 mil bag of saline, and we're running that at 1 mil per kilo per hour. So 1 times 10 gives you 10 mil per hour, and this is using the dose of 0.01 mg per kg per minute. And last, we've got dopamine. So dopamine is a precursor of noradrenaline, and it's the medication form of a substance that occurs naturally within the body. It works by improving the pumping strength of the heart and improves blood flow to the kidneys, and this helps increase the blood pressure. We use it to treat hypertension during anaesthesia, but it can also be used when your patient's within the wards as well. It's short acting, so needs to be given as a CRI. You do need to be careful with your dose rate though. If you're using a dose rate of less than 10 micrograms per kilo per minute, this causes vasodilation and would increase your heart rate and contractility, therefore improves your cardiac output and organ perfusion. But if you're using a dose rate greater than 10 micrograms per kilo per minute, this would cause vasoconstriction and reduces your peripheral blood flow. So your adverse effects can be hypertension at too low a dose, but hypertension and arrhythmias at too high a dose. If you do notice these, they are usually managed by altering the CRI dose or stopping it altogether. So an example to calculate your dopamine. So we've used a weight of 25 kilos. The dose we want to start would be 5 micrograms per kilo per minute. The stock concentration is 40 mg per mil. We would use a 100 ml bag of saline and the fluid rate would be 1 ml per kilo per hour. So to start off, we would do as 5 times 25, so we need 125 micrograms per minute. So then we would times this by 60, so then we would need 7,500 micrograms per hour. But we would divide this by 1,000 to get our milligrams, and that would be 7.5 milligrams per hour. So then for our fluid rate, we want 1 ml per kilo per hour times 25 kilos. So we want that running at 25 ml per hour. And we would divide our milligrams per hour, which is 7.5, by 25. So that would give us 0.3 milligrams per mil. We would then times that by the bag volume, which is 100 ml. So in the bag, we want 30 milligrams per 100 ml bag of saline. So the 30 milligrams divided by the stock concentration of the drug, which is 40, would give us 0.75 ml. So therefore, we would add 0.75 ml to a 100 ml bag of saline, and we would run that at 1 ml per kilo per hour, and that gives a CRI of 5 micrograms per kilo per minute. And as with the ketamine, you need to make sure you remove 0.5 ml of saline before adding the dopamine to the bag.